one comment I want to make is, sometimes I've seen cases where the amalgam ring is used. It's a bad IFUS case. The amalgam is removed, and during the OVD removal, there's prolapse, and the iris is manipulating around, and it's quite traumatic. So I don't know if you have any pros on that, but one of the things I'll say is a couple of things. That prior to removal of the amalgam ring, you can go in with a 27-gauge cannula and remove the OVD in a dry fashion. So you basically remove the viscoelastic underneath the lens, then remove the amalgam ring with the viscoelastic in the AC, hydrate the incisions to avoid prolapse through your main incision in your side port, and then under the right flow characteristics, basically remove the viscoelastic and perhaps even inject some Michael if you have to. Because I know sometimes there's questions about, after I remove the amalgam ring, I have to remove the OVD, and in a real bad IFUS case, you can get prolapse of the wound or to the side port. So those are just some points about a bad IFUS case. Okay, well, I'm going to, these are my disclosures here for the meeting. My case is entitled Restoring the ReSTOR, ? And I'm just going to show you the case presentation. This is a 68-year-old male who presented, actually this case was in 2011, but the previous surgery was in 2006. Had bilateral ReSTOR. This is the original 4+ ad ReSTOR with the spherical design. He's been unhappy with his vision since the surgery. He wears glasses for distance and computer, which is not what he wanted. He's not for near, though. He doesn't wear for near. And he has visual quality issues, and he notes vision is worse recently in the right versus the left. That's his refraction. You notice he's got some hyperopia, and he's got some astigmatism present. He best corrects, as you see, as partly from PCO, primarily from PCO. He was 20/20 before, right after surgery. PCIOLs are in the bag. Exam is otherwise unremarkable, and you see that on the corneal topography, he's got some cylinder here. Steep axis is about 75 degrees. So very quickly, maybe we'll get the panel here. This is an unhappy original ReSTOR, spherical, 4-ad patient, post-op hyperopia and astigmatism. And you've heard the complaints since day one. He hasn't been seen clearly. He wears glasses for distance and for intermediate. And he's got a bit of PCO right now. So what are your thinking as far as what options would you provide this patient and then going forward from that?
Well, I think the most important point you made is that he's been unhappy from day one. And I mean, that's the key thing. I said, did you ever have a period after your surgery you were perfectly happy with your vision? Yeah, it was great for 6 months, and then it wasn't great. So, now you're talking about somebody who, regardless of what they have and a little bit of refractive error and whatnot, it's a quality of vision question in my view as well. So that's what I want to get down to in this case.
I kind of think you need to have a greater discussion about exactly what it was that he's unhappy about, because it could very well be the hyperopia. And if with the distance correction, if you said, gee, would you be happy with your vision without glasses the way that you see with your distance correction, that would be a really important question for me. I think that's something I would want to know. And I'd also want to know what's the patient's personality. There are some people who are going to be unhappy regardless of how well they see, because they're just unhappy people.
Yeah, he's not an unreasonable personality. Actually, he's lived with this for the last 5 years, or 4 years. So,
has he accepted glasses in the meantime?
He's having trouble with glasses, and he did try glasses though, and that's why he was doing this. We did talk about laser vision correction,
right?
To correct the residual refractive error. I did explain to him that he would not have necessarily the computer vision that he's looking for, and he's really a big computer user.
Yeah, well, I mean, these are the things I think we're both converging on. Is the question of, is his quality of vision fine with glasses? And if it's not fine with glasses, then you've got an unhappy.
Yeah, that's right. So basically, just to move forward here, we basically discussed about doing an IOL exchange to address quality issues and also to address what his visual requirements were. We had a discussion whether we would go monofocal, whether we would go from some monovision, or whether we would go for the newer aspheric ReSTOR with the 3-ad. Again, I'm putting you on the spot here. What do you guys, you don't know the patient, any thoughts on that?
Well, like Mike said, I think, if the guy in the office with correction or he's in glasses and he's still not happy with the quality of his vision overall, then I think you're really pushing it to go back to square one with another multifocal lens. So
I don't know. I still want to know more.
We don't have time for everything you want to know.
Seriously. Many times when people are referred to me that are unhappy with, I get people referred to me, Mike, take out the ReSTOR lens, the patient's unhappy. And probably I'd say 8 out of 10 of the times, when I sit down and really talk to the patient, the reasons that they're unhappy are not multifocality. It's, maybe he's unhappy with the glasses because they're uncomfortable on his face and it makes his nose sweat or it's too heavy on the ears. I hear this stuff. And if that's the primary issue, you're going to make him really unhappy by taking out the multifocal and putting in a monofocal, because it sure as heck isn't going to make his near vision better, and it's sure as heck not going to make his intermediate vision better. So if it was strictly an issue, those I think are critical. So this might be a case where it says, gee, if the intermediate vision is the problem, maybe this is an appropriate setting to switch to a +3 ad with a proper distance aim. I think that the crucial element is really what is the quality of his vision. Like if he says, gee, my vision is fine in the distance with my best correction, but I don't like the glasses, I can't do my intermediate, that's a very different story.
Yeah. So, yeah, I mean, and you've hit the great points here. I mean, he's a reasonable guy, and we've chatted about this, and so basically, just to move forward here, we did decide to do an IOL exchange, and we did decide that we would go for the ASCRS ReSTOR +3, understanding, no guarantees, but this would hopefully, if we correct his refractive error, and we can enhance his range of vision for intermediate, that's what our goal would be. So I'm glad nobody mentioned laser capsulotomy here, of course. He's got PCO, but we knew, though, as Gary said, that his problem started before the PCO. If his problem started just with the PCO or in a different patient, it might be a very different story. So
just a quick tip, if I can take 10 seconds to do it. Sometimes it's not really clear if they had maybe some plaque at the time of their initial surgery and you're trying to debate, is it the PCO, is it the multifocality? One of the things that you can safely do is, while a laser capsulotomy really burns the bridge for an exchange safely, you can actually go in, open up the capsular bag, and do a primary posterior capsulorhexis, and then leave the implant lens where it is, and then ask them, how are you? And if everything is solved, you go away, you're done. If they say, gee, I'm still not happy, then with a primary posterior capsulorhexis, unlike a capsulotomy with a YAG, you can go ahead and exchange that lens very safely without vitreous prolapse.
I love microinstrumentation, and I love the fact that as anterior segment surgeons, we've embraced microinstrumentation over the last 7-8 years. It's become a mainstay of what we do with any complex case, whether it's cataract or IOL related. And there's a variety of different microinstruments that are available in the market. I'm proud to say that MST really has been the leader from the beginning and has continued to innovate from the beginning and continues to do so. We won't show everything in this particular video, but I'm going to highlight some of the microinstruments and micrograspers that we use to hold things, hold capsule, hold iris, hold lens, micro scissors that we can use to cut sutures, and tying forceps to tie in the eye as well. So, for IOL exchange, and I've had a chance to use so many different variety of different options. The bimanual technique of holding the lens with one instrument, like a micrograsper, while cutting it with a large, or a larger, I should say, 19-gauge IOL cutting head, is, I think, the most controlled way to remove these. So basically, the tools I want in my OR are microinstruments, and also at least having an IOL cutter there with those microinstruments. I like using different types of hooks. We've seen hooks earlier, Sinskey and Kugeln hooks. I'll show you how I use these to manipulate the lens, get under the capsule, other variety of sources. The viscoelastics are going to be really key here to open up the capsular bag, protect the corneal endothelium. This case is about 4 or 5 years old. I'm also concerned about getting the lens out of the bag. I'm concerned about the zonules. Any pseudophakic patient going back into the eye, we have to worry a little bit about this. And so having some sort of capsular device available, having iris hooks available if we need to get the pupil large enough, are going to be important as far as manipulating the capsule as well. So let's get to the video here just to show what we ended up doing here. This is the patient here, and by the way, he's got astigmatism, so why not treat that? We're using a two-ray marker with a Mendes ring to mark him at about 75 degrees. I'm going to use a dispersive and a cohesive agent, a soft shell technique to protect the cornea, about a 2.75 limbal incision. Now here's how I like to do as far as opening the bag up. I like to use a micrograsper to actually get under the capsule, lift up the capsule, and then use a Sinskey hook to hook the capsule as we show here. It's amazing, even after how many years later, we can still get underneath the capsule like this technique. Once I lift it up, I then inject viscoelastic. I like using cohesive, 360 degrees around the anterior capsule to basically lift off the anterior capsule from the optic edge. Thankfully, this capsulorhexis was over the optic, making it easier to dissociate. If the anterior capsule and posterior capsule were fused, it makes it a little bit more difficult, but is not impossible. You see we've done 360-degree viscodissection. We're going to also then use a Sinskey hook to get underneath and inject underneath the optic. Now, the haptics are at 3 and 9. We're sitting temporally here.
Can you just pause for one
Yes.
second? So that's the question. I think it's great that you have the scissors program in mind because it automatically allows you to deal with what you're likely to deal with here, which is a haptic that's fibrosed into the equator. And you've already got the instrument right on the table, and I don't know if you're going to handle it that way, but I think that's why I automatically now go to the cutting thing because I don't know how much cutting I'm going to have to do. So I'm, there it is.
The scissors are great, not only for the optic, but as you mentioned, to disconnect the haptic from the optic. And as Gary mentioned, one of the big challenges here is that bulbous haptic in these one-piece lenses in the capsular fornix. It can be quite adherent and difficult to extract. We're injecting, though, we're trying to dissociate, again, the anterior and posterior capsule, injecting under both haptics. Often there's a bit of a cocoon sort of around the haptics. Now what I'm going to do, I'm going to prolapse the optic with a Kuglen hook and a viscoelastic cannula underneath and bring the optic anterior to the anterior capsule. The haptics still remain, but they're twisted now, of course, under there. Continuing to do some more viscodissection. Here I'm going to again use the micrograsper and basically use the Kuglen hook. You see I basically use the Kuglen against the capsular rexus edge as I pull the haptic out. Fortunately with the viscoelastic dissection, 2 hands here, one for counter traction, which was the Kuglen hook, and one with the grasper to pull it out. I feel I have ultimate control in getting the haptic out. So thankfully one haptic went out quite well. We'll bring it into the anterior chamber. The second one is more challenging. Look, I'm basically bringing it forward, but that bulbous end is stuck down there, and that's not a good sign. You can't quite see the end of it, but you can see that the shaft of it is pretty stuck. So I'm going to continue to do more viscodissection, seeing if I can get it loose. But you know what? It's going to be safer to cut that haptic out and then basically remove the optic. Here we're going to hold the optic here with a micrograsper, and we're going to now use the 19-gauge IOL cutting scissors to basically bisect the lens in half. Look at the ultimate control, no twisting, we're away from the cornea. Ensure we inject enough viscoelastic above and below the optic to avoid trauma to the cornea or the iris in the capsule. We'll then remove each hemi section here with the micrograsper. We have the remaining haptic here. We could certainly leave it. I think it wouldn't be wrong to leave it. I am going to see if I can dissect out the haptic from the basically fibrotic ball around it.
Why?
Well, a couple of things. Number one,
ego thing.
Well, yes, part of the ego thing, but I'm sure it is. But I felt that in this case, I felt I wanted to put a CTR in for centration. That's the bottom line. Now, why? It's a multifocal lens. Number one. Number two, you do these cases. You see sometimes there's some phacodenesis after or pseudophacodenesis. I felt that even with my manipulation that maybe the capsule might be a little bit of an issue. So you can see I basically am dissecting and basically feeding off the fibrotic tissue away from the haptic. It comes out actually. See, it comes out fine. So if I struggled continuously, I would obviously leave it and maybe trim it further. I'm now going to use a 27-gauge cannula. I'm not using my IA handpiece here. I feel I want to maintain control. If I go in with an IA handpiece and I'm removing the retained cortical material or Sommer rings, I'm concerned that I may lose control. And vitreous can emerge. The capsule may become difficult to manage. So I'm basically going to just use dispersive here to essentially extract some of the lens material and fibrosis. There's a bit of cortical material and Sommer rings. Again, I think you can leave it. I don't think you need to necessarily remove that Sommer rings. I'm going to basically remove some of the posterior capsule fibrosis that's present. This avoids the need to do an early capsulotomy, although we probably will need it long term.
I think, Mike, anybody who has a vacuum of 650 plus on their screen is probably going to go for broke here. What do you think?
I don't know. It's not 9:30 yet, but I sure wish you'd
It's
do a
linear
post-capsular
control.
access.
It's linear control. So I'm basically vacuuming essentially. I'm injecting more viscoelastic to get the bag expanded. More dry aspiration. It's a little bit tedious. Now I should have probably put a Malligan ring or some iris retractors to sort of visualize here, but I'm using a Kuglen hook with one hand, and my other hand I'm basically pulling back on my plunger to basically very tediously remove all that viscoelastic. Cohesive OVD is injected here, expanding the bag. I'm really going to hyper-expand the capsular bag. Here's my CTR being injected. I'm holding the capsular rexus edge to prevent any excessive movement. We now have a nice CTR in the bag for centration. Here comes the multifocal toric. We're going to rotate the lens at 75 degrees in position. I'm going to look at my marks, of course, here that are going to be helpful to sort of identify it. Now, in a small pupil, it's a little bit hard, but you can still see the little marks. You can see the 3 marks on the optic haptic junction. Hopefully, you can see them there. And we're going to then remove some OVD with a dry aspiration underneath the lens, again, just for more control value. Check the orientation again to make sure that we are in good position here. So I basically have removed most of the OVD from behind the lens. We'll continue to remove the OVD here. Again, I just feel more control removing it with the dry cannula. It's important to remove the OVD.
Okay, Ike, can we stop for a half a
Yes,
second?
please.
Just one quick comment. What Ike was doing there, and I don't know if everybody in the audience caught it, that was his astigmatic adjustment built into the lens. Here in the United States, we're still working in 1992, and we do not yet have the toric version of the ReSTOR, but he apparently has that available up in Canada.
Yes, I'm sorry, I should have mentioned that actually. I forgot we're in the U.S. for a second. First world country. Basically, yeah, this is the ReSTOR, this is multifocal toric, so yes, I'm basically aligning the toricity, the steep axis here, the lens with the steep axis here. Small pupil makes it a little bit difficult, but using some retraction of the iris can help. So basically, that in a quick nutshell is essentially what we did for this patient. We did his other eye too, and I'm not kidding here. I think my fellows in the audience here, and she probably can confirm that. But basically, this is his EMR report recently. You can see he's quite happy. He's had a capsulotomy. He's 20/25, 20/20 J1. He's reading at a happy and intermediate at a happy distance. Unfortunately, we had a great result with this approach here for the right patient, of course, in terms of the discussion. So that's basically a technique and thoughts in terms of an IOL exchange. We obviously went to the extreme level here with another multifocal, but hopefully those are some of the pros on tools and techniques. I'm going to have Mike come up and set up here, but Gary, please feel free to add any comments or questions or concerns.
No, that was a great case, Ike, and we see this, obviously, you see it week in and week out, and I think the points that you made earlier about deciding what you're going to do with this patient is key. I think having somebody that you think is flexible enough to deal with the idea of, you know, a multifocal for multifocal IOL exchange, I mean, that's not typically the common way to go. Usually it's a multifocal for a monofocal, in my view. And in those cases, I wouldn't have gone to the extremes that Ike did in terms of extracting the haptic and whatnot. I think just put the lens in at the other orientation, the other meridian away from where the haptic is, a typical exchange thing that I would do. So.
Yeah, and that would have been fine because the haptics would have been at on the axis of the toric lens. If the axis was horizontally.
Right. I don't think we all realized that you were going for a toric for an exchange, in which case, obviously critical to a toric ReSTOR, and then obviously critical to make available all the equatorial portion of the bag. So,
great. Thank you.